Hello and thank you for joining in on today's training. Heart & Solutions is a proud provider of CE-eligible trainings for our counseling community. This training may be eligible for continuing education credit hours through either the National Board for Certified Counselors, provider number 7376, or the Association of Play Therapy, provider number 21-645. To obtain CE hours for today's training, be sure to follow the steps in the description below to find and take your quiz.
Dr. Robert Black lets us know that adverse childhood experiences are the single greatest threat to our society today, which sounds like a pretty dramatic quote, right? But when we explore what adverse childhood experiences are, and we explore the impact that they have on children and adults and intergenerational trauma that can result, it really is quite fitting to make that statement. And we're going to talk a lot today about exactly that, right? Why these are a threat to our society and what we can do as helping professionals to help address the impacts of ACEs. To understand how to counteract and help with ACEs, it's important for us to understand where ACEs come from and learning about the difference between stress, right, and toxic stress or traumatic stress. And we all have stress, right? Positive stress, as it says here, it's normal. It's a healthy response to stressful events, difficult events. A great example is the first day of school or the first day at a new job, right? We get that, I'm not quite sure what's going to happen feeling. We're a little bit nervous about the friends that we might meet or the expectations that might be placed on us. And it's that stress that gives us the ability to enter that situation, right? And is a stress that we need to experience. And like it says, is a positive piece of our lives. From positive stress, we find ourselves sometimes in a situation of tolerable stress, right? So this stress isn't the exciting stress of a new job or a new adventure, but it's stress that we can handle. Our body recognizes something's wrong, something's different. This stressor isn't going to dissipate quickly. So an example of this may be the loss of a family member. And I should caveat there, the loss of a family member with a strong support system. So it's a stress that we don't want to be experiencing. It's a stress that makes our body recognize, oh, I need to activate my stress response. I need to be ready to respond to the situation that's happening. But I've got a support system. I've got a network. I've got coping skills. I can get through this. I can tolerate this stress, even though I don't like it. Of positive and tolerable stress is what we call toxic stress. And toxic stress results from the prolonged activation of that stress response. So I've got a little bit of a stress response. I've got a situation that's uncomfortable that I don't like. When that lasts longer and longer and longer, and it's happening more frequently and more often, we find ourselves in a state of toxic stress. Our stress responses in our body are building up. They're constantly firing. They're not getting any sort of reprieve. And this can come from things like chronic exposure to violence. This can come from the ACEs that we're going to talk about today. So just understanding that when we talk about stress in and of itself is not inherently bad. Stress is positive. Stress helps us perform. Stress helps us do the things that we need to do when it's positive, right? Stress is also important when it's tolerable. Again, it lets our body know, oh, I need to do something different. This is not my everyday occurrence. Where we become concerned about stress is when we enter that level of toxic stress. I do have a short video for us to watch. I try not to use them a lot. This one's about 4 minutes, but I think that it just does a really great job at highlighting how our brains are built, right? The title of this. So I will pull this up and then we'll talk kind of about what the video is showing us. But I think it just does a wonderful job of highlighting the importance of understanding where this toxic stress is coming from and its role in understanding ACEs.
Science tells us that the experiences we have in the first years of our lives actually affect the physical architecture of the developing brain. This means that brains aren't just born, they're also built over time based on our experiences. Just as a house needs a sturdy foundation to support the walls and roof, a brain needs a good base to support all future development. Positive interactions between young children and their caregivers literally build the architecture of the developing brain. Building a sturdy foundation in the earliest years provides a good base for a lifetime of good mental function and better overall health. So just how is a solid brain foundation built and maintained in a developing child? One way is through what brain experts call serve and return interactions. Imagine a tennis match between a caregiver and a child, but instead of hitting a ball back and forth across a net, various forms of communication pass between the two. From eye contact to touch, from singing to simple games like peekaboo. These interactions, repeated throughout a young person's developing years, are the bricks that build a healthy foundation for all future development. But another kind of childhood experience shapes brain development too, and that's stress. Good kinds of stress, like meeting new people or studying for a test, are healthy for development because they prepare kids to cope with future challenges. Another kind of stress, called toxic stress, is bad for brain development. If a child is exposed to serious, ongoing hardships like abuse and neglect, and he has no other caregiver in his life to provide support, the basic structures of his developing brain may be damaged. Without a sturdy foundation to properly support future development, he is at risk for a lifetime of health problems, development issues, even addiction. It's possible to fix some of the damage of toxic stress later on, but it's easier, more effective, and less expensive to build solid brain architecture in the first place. One of the things that sturdy brain architecture supports is the development of basic emotional and social skills, an important group of skills which scientists call executive function and self-regulation can be thought of like air traffic control in the child's mental airspace. Think of a young child's brain as the control tower at a busy airport. All those planes landing and taking off and all of the support systems on the ground simultaneously demand the controller's attention to avoid a crash. It's the same with a young child learning to pay attention, plan ahead and remember, and follow lots of rules. Like all of us, kids have to react to things happening in the world around them, while also dealing with worries, temptations, and obligations on their minds. As these demands for attention pile up, air traffic control helps a child regulate the flow of information, prioritize tasks, and above all, find ways to manage stress and avoid mental collisions along the way. Having this ability is a necessity for positive and level mental health. Developing effective air traffic control, overcoming toxic stress, and building solid brain architecture are things kids can't do on their own. And since strong societies are made up of healthy, contributing individuals, it's up to us as a community to make sure all young people have the kinds of nurturing experiences they need for positive development. To build better futures, we need to build better brains.
So again, exactly what we've been talking about. We have a role in helping build those brains. Toxic stress can and does happen. And like we talked about, that toxic stress is that long-lasting stress. And unlike tolerable stress that can be attended to with a support network, toxic stress is especially true and most at risk when a child doesn't have a supportive adult. That supportive adult doesn't necessarily need to be their primary parent or caregiver. If we can find a community member, right? A teacher, a mentor, a bus driver, right? Someone who can become that positive support for them, we know that we have an exponentially better chance at reducing that toxic stress and helping those brains heal and recover from the ACEs they've experienced, because ACEs are what cause that toxic stress. And this next kind of paragraph on this slide is there's a lot of information, and I promise we'll break it down. as the training continues. But those ACEs cause stress. And like we talked a little bit about, that toxic stress results in an excessive activation of stress responses. And so we have all of these hormones built up, cortisol in particular, and it starts to damage the body and the child's brain. It can reduce the size of their hippocampus, which can impact negatively their memory, their ability to fight disease, right? Lifelong hyperarousal and increased stress, right? This is what's going to spiral into seeing some behavioral disorders, right? A lot of times we get calls, that kids are having a hard time concentrating in school, or they're getting in trouble. And when we look at ACEs, we see, we've got a pretty high ACE score here, right? And we haven't had the best supportive network. We know that change to the brain, that damage to the hippocampus is really what we're tackling now, and having to rebuild and put some pieces in place to help those children overcome that ACE experience. So a lot of us are aware, hey, ACEs have been around for a while. They were discovered really on accident, right? It was Kaiser Permanente doing an insurance study, right? That found, we've got some life experiences that result in higher instances of disease and chronic illness. Let's explore this a little bit more. So in 1998, the first study on the impact of China was completed. It was 10 questions, right? 10 pretty straightforward yes, no questions. Hey, have you experienced this scenario? And the ACEs test hasn't changed much since 1998. It's pretty straightforward as a way to gather information about some of the most difficult life events that the child may experience. This is what it looks like. So how to find your ACE score, right? So like it says at the top, it's meant as a guideline. I use a few other assessments in my own practice that are a little bit more comprehensive. But these are the original 10 questions. And we'll talk a lot more about these, right? But thinking even on our own experiences, did a parent or another adult, older adult in the household, often or very often swear at you, insult you, put you down, or humiliate you, right? Act in a way that made you afraid you might be physically hurt. Did a parent or other adult in the household often or very often push, grab, slap, or throw something at you, or ever hit you so hard that you had marks or were injured? Did a family member, an adult, or another child in your household ever touch or fondle you, or touch your body in a sexual way? Did you often feel that no one in your family loved you or thought you were important? Thinking about if you ever were in a situation where you didn't have enough to eat, or had to wear dirty clothes, or didn't feel like anyone could protect you, right? Did your parents have substance abuse concerns that made it difficult for them to take care of you? Did you experience a separation or divorce? Was there any physical violence or aggression to other adults in your household, right? Instances of domestic violence. Another question kind of related to substance abuse, right? What was that environment like? Questions about mental illness, right? Did you live with a family member or household member that attempted suicide or had mental health concerns? Has anybody in your family or household gone to prison, right? Like, these were the 10 questions that Kaiser Permanente noticed, we need to explore these, because when somebody has experienced these events, the chances, again, of them having increased issues with chronic health skyrockets. And knowing someone's ACE score is a pivotal point to being able to move things forward and help them heal. As we grow and we continue to explore ACEs and the impact of ACEs, we're also aware that there are some additional things that we need to be asking about. This assessment in particular goes on to explore community violence, witnessing other acts of violence, terrorism, lots of medical issues or surgeries, being exposed or experiencing racism or discrimination, bullying, including online and cyberbullying. Those are all incredibly important things for us to consider as well. I use another screening inventory known as the Traumatic Events Screening Inventory, or the TESI for short. It's very similar in structure to the original ACES questions, but it explores kind of a wider range of things as well, including things like animal bites or attacks. It talks about the medical issues. It talks about terrorism. It also talks about witnessing violence or terrorism on TV. And some of you that have attended some of my other trainings may have heard this example before, but the one that always comes to mind for me is we were working with a young child who had been sexually assaulted, and it was a pretty high profile situation. And the offender was caught and was being prosecuted, but it had made the news. And this child was pretty young, and their perpetrator's mugshot was on the TV quite frequently for several weeks. And one of the things that we came to realize is that this young child thought that her perpetrator was in her home and could see her, and didn't understand that just because the picture was on the TV didn't mean it wasn't a two-way communication. So we had an additional level of trauma related to what many viewed as a positive, right? This perpetrator's been arrested, like things are moving in the direction of, with the judicial system. But because of the exposure on the TV, it was another piece of that trauma puzzle for that child. So just asking all of those questions and really understanding from the child's point of view what that traumatic experience was like. I do that whenever I work with children. I'll complete an ACES score or a TESI, but I'm doing that with the child as well as with the parent, often in separate settings, because what may be incredibly traumatic for that child, right, may not be something that shows up on the parent's radar, right? And vice versa. I've had situations where parents are like, oh my goodness, like we experienced this horrific car accident, right? And I thought that everyone was going to die, and it was really scary. And, that was a traumatic event for them. And the child may go, no, right? Like that's not a big deal. What was really scary for me is the time that whatever. And so understanding perceptions of trauma as well is very important. Just to give us some numbers, this is from 2020. Almost 35 million children in the US alone were impacted by ACEs. 110 somewhere in the spectrum of ACEs, but staggering numbers, right? And again, that's just in the US that we're looking at 34.8 million children having been impacted by some sort of ACEs experience. So what are they, right? We've talked about why we need to know about them and how they impact our brain. But ACEs in and of themselves are traumatic events that occur during childhood. Right? So between those ages of 0 to 17, like we've talked about, they have long-lasting negative effects on health and overall well-being. And we talked about, again, coming from that original Kaiser Permanency study, there's 10 primary ACEs with some additional points of consideration being added as we continue to learn more. But looking at those three major categories, right, of abuse, neglect, and household dysfunction, we have three primary types of abuse, right? Physical abuse, emotional abuse, sexual abuse, anything that falls under those umbrella categories, as well as physical and emotional neglect. Household dysfunction could be a range of things: living with a household member with severe mental illness, the incarceration of a relative, a mother who was treated violently, substance abuse, and divorce or separation are all things that we want to take note of when it's assessing ACEs. In the original study, over 17,000 participants were questioned. Again, the original study was not to look at trauma. It was not to look at adverse childhood experiences. It was to look at health issues, and society in general is much more willing to answer questions about their physical health than their mental health. And fortunately, one of the outcomes of that then was we had a giant sample size that we were able to gather data from, and then happened to go, oh, there's a next step here. But of those 17,000 original participants, 64% of them experienced at least one ACE, and 54% experienced more than one. So what that really tells us is it's highly unlikely that if somebody has experienced one ACE, they haven't experienced more, right? So it can happen where somebody has a life that is great and wonderful, right? And kind of everything goes according to plan, and they have one kind of blurb on that radar where something really negative happened. But often what we see is that when somebody has experienced one ACE, oftentimes it is joined by at least one other. Some recent statistics as well, right? Almost 50% of children, so 35 million, have experienced trauma, right, of some sort. So half of our world's population of children that we can access, right, have experienced some sort of traumatic event. We know that 60% of children who witness domestic violence are under the age of 6, right? So when we think about the lifelong impact and where children are at developmentally under the age of 6, just thinking about, being in that perspective and witnessing domestic violence at such a young age and the outcomes that can happen as a result. 76% of children who have been exposed to 5 or more ACEs in those early years, those 0 to 3 years, we know are going to face delays in language development, emotional development and regulation, overall brain development. There's just so much that these kids are facing and experiencing when those ACE scores continually rise. Thinking about just some cultural considerations and some pieces to be aware of, looking at overall ACEs, divorce and economic hardship is the most commonly experienced ACE, regardless of race or any other cultural considerations. We do know that Black children are more likely to experience the incarceration or death of a guardian, and Hispanic children are more likely to live with a guardian with substance abuse issues compared to other races. So increasing our knowledge of those cultural considerations, making sure that we are asking culturally relevant questions. And again, like ACEs it's not done, right? It's really easy to yeah, here's our ACE scores, here's what we do with them. We're learning every year and adding that information to the approaches that we're taking with children and their families. A little bit closer to home, 64% of Iowa adults have experienced at least one ACE. And this data is about Iowa adults. We know that adults were once children, right? So thinking about those adults have experienced ACEs, but it means that in their childhood, that's when these adverse experiences happened. 17% of our Iowa adults have experienced 4 or more ACEs, significant levels of stress. Adults with higher ACEs, we see higher reports of ACEs of adults of color, adults with less than a high school education, and adults living in poverty, right? So we have those social factors. Often, those are associated with higher ACE scores. We've talked a lot about why it's important, right? And where ACEs come from and where they fall into kind of our life cycle and development. Before we're even born, right? We are entered into a world of gestational, intergenerational, historical trauma, right? There are things we could do a whole other training on epigenetics, right? And a whole world of how the genetics of our ancestors impact our brains. And it's fascinating. But all of that is given to us before we are even out of the womb. And so we are entering this world with a host of historical trauma. We're brought into this world in social conditions and where we are born and raised that out of our control, right? And the world to which I am brought into then sets me up for those adverse childhood experiences, and thinking about what I may experience as a child as a result of my historical trauma and where I'm living and my family members and my household. And as I experience those adverse childhood experiences, I have disrupted neurodevelopment, and my brain is altered, and not just in a social sense, or, you know, a psychological sense of, oh yeah, like trauma alters the brain. No, like physically, right? We take pictures of brains, we see the damage, we see the change in size to that hippocampus. As a result, then, right, we're at increased risk for disease and disability and social problems and an early death. And so scattered around this graphic are kind of the real world things related to that graphic, right? I think it's easy to kind of think, oh, like disrupted neurodevelopment. Yeah, okay, like my brain has some changes. What does that mean? What does that mean in real life? And what that means in real life is that children and adults with higher ACE scores may experience increased depression. They may have less education, increased suicide attempts, greater IV drug use. They're at an increased risk for diabetes and traumatic brain injuries and anxiety, unattended pregnancies, difficulties with birth and higher rates of fetal death, sexually transmitted diseases, difficult relationships, increased risk for cancer and substance abuse, right? Like these are real world things. And these are the things that we're aware of, and we want to try to prevent and limit for children that have had adverse childhood experiences. Symptoms of ACEs in children, right? We're going to talk kind of like, what does this look like? And what we know is that from the time that children are born until about age 11, their brain's primary focus is on building attachments with other people in their life, developing language, forming memory. We talk a lot about kind of that 11-ish age. Bruce Perry does some wonderful work we're going to talk more about in a little bit. We've got some wiggle room, right? With kids under 11. We can do some fabulous work with kids past that age as well. But the sooner that kids can get in to therapy, the sooner we can get them connected with supportive adults and start rewiring those neurons and the pieces of their brain that are still super elastic, the greater likelihood we have for more positive outcomes, which is exactly what Paris Goodyear-Brown is talking about as well. Repeated actions train our neurons to fire, right? So the more often I'm doing something, the more my brain connects, this is how I do this, and this is the reaction I have when I do this, and this is the outcome when I do this. And so as kids are developing, when they're stimulated, when they fall down, right, and they get a hug from a caregiver, their brain starts to learn that, okay, when I'm hurt, someone's going to take care of me, right? That happens over and over and over again, as opposed to a child who's experiencing neglect and gets hurt or is hungry or sad and no one's coming, right? And no one's coming. And their brain starts to learn, okay, like when I feel like this, I'm on my own, right? No one's coming. No one's coming to help me. And we see that play out, right? I worked with a little girl one time who spent the greater part of the first 18 months of her life living in a car seat inside of a dog kennel. And after those 18 months, she was placed in an amazing foster home and pre-adoptive home, and things are great. It's been 7 or 8 years now. But those first 18 months, her brain's neurons had learned no one's coming, right? It doesn't matter how hungry I am. It doesn't matter what I need. As she's, her brain was trying to focus and build those attachment pieces and those memory pieces. Her exposure to ACEs led her brain to know doesn't matter, right? And so we spent a ton of time in therapy training those neurons to relearn people can come and people can help. And it's not an easy task at all, but our brains are incredibly resilient, especially in children. And we'll talk more about resilience later on today. But that's what we want to do, right? We want to counteract those neurons that have gotten trauma messages. Like we've talked about, more exposure to ACEs, persistent exposure to ACEs, causes the body to be in a constant state of stress, right? It leads to that toxic stress situation. If you think about any time in your life where you've gotten news that you didn't expect to get, right? Or weren't prepared to get. We think about, some of the worst moments of somebody's life. They go to the doctor and they get a life-altering diagnosis, right? Or one of their family members is gravely injured. The second that doctor says the words, right? Oh, you have this diagnosis, or your family member is very, very hurt, everything sort of turns off, right? And later on we go, I don't know what they said, right? I know they said this thing, but I don't know anything else. Let me go back, and now I need to ask questions or kind of reprocess that. Our brain shuts down in those moments of high stress, right? So if we imagine being in that level of stress constantly, we can for a second kind of take a glimpse into how that may impact our memory and our language and our anxiety, right? Like constantly being at that highest state of hyperarousal. And then we wonder why it's hard for kids to concentrate in school, right? Because my brain is acting as if it just got the scariest message of its life, even though you asked me to get a pencil out for my spell. So as that exposure to ACEs increases, right, our stress pathway becomes so dysregulated, right? Again, constantly on edge. We talked about the shrinking of our hippocampus, right? It is hard to learn and to remember, and I'm worried all the time, right? And so and now you're asking me to remember my spelling test or memorize math problems. And that is really, really hard. We also struggle with emotional processing and regulation, right? We see these physical changes in the brain, our prefrontal cortex, right? If we take 2 scans, and usually I add them in, I should have, we have decreased gray matter, right? We're not just hypothesizing that, oh, there's some impacts to the brain. It's there, and it's clear out and evidenced on brain scans. Our amygdala grows and our gray matter decreases, and we are hyper vigilant, and we can't control our attention, right? We are constantly on edge as we experience more ACEs and we grow up with those ACEs. We also struggle to kind of experience pleasure, right? Rewards just aren't as rewarding. When I work with kids with significant attachment disruptions, often caused by high level ACEs, I hear a lot of teachers and parents, well, we've tried everything, right? We have the sticker chart. I don't care, right? The sticker chart will not work. And so I talk to a lot of like our BHIS providers. If you're working with a kid who is non-responsive to a reward system or a sticker chart, we need to be doing a more in-depth exploration of their trauma history and their ACEs, because that reward experience isn't the same for kids that are in a toxic stress situation. That connectivity piece is disrupted as well. The parts of the brain that help us kind of understand situational awareness and what our responses are supposed to be is disrupted. And so that awkward, sometimes inappropriate, right, just off base social interaction can be a result of high ACEs and constant toxic stress as well. Right on the outside, like we don't see all this stuff on the inside. We don't walk around with brain scans of children. What we see is these big externalizing, acting out behaviors, our naughty kids, right? Our kids that are always in trouble and causing trouble and hurting peers and breaking things. We also see children who internalize behaviors. Some of the kids I worry the most about in the school setting in particular are the kids that are never in trouble, right? Like picture perfect, like I have to, everything is great. Those are kids I want to ask questions about. as well. Internalizing behaviors often go unnoticed and underassessed because there's so much easier to deal with in our systems than the externalizing behaviors. But we can see a lot of anxiety and withdrawal from children with ACEs, as well as that difficulty with attention and executive functioning, right? Which is exactly what our kids are being asked to do day in and day out, right? Is to use those executive functioning skills. Even the graphic in the video we watched earlier overwhelms me at times, right? Because it is, okay, do your homework, share your toys, do this, remember this, pack your lunch. Like, holy cow, like that's a lot for any of us to do. And they're being asked to manage that executive functioning all day long. And that is increasingly difficult as our toxic stress increases. So again, we talked about these externalized behaviors, right? And those are the ones that are often why our agency gets phone calls. They're often the ones that parents or caregivers, right, get calls from school about. But it can look very aggressive. There's a lot of inattention. There's a lot of risk-taking type behaviors. And these just don't go away, right? We can't ignore them and just hope that they disappear. Without being addressed, they can worsen as that child gets older. And those risk-taking behaviors can become even more dangerous and more consequential. We often can see other behaviors as well. So learning difficulties, delayed cognitive development. We've talked a little bit about the difficulty forming attachments with others. And those attachment difficulties can go two directions, right? So sometimes I think we often think about children with disrupted attachments or attachment disorders as not forming attachments, right? They have a hard time connecting to adults. They push people away, which absolutely can be a sign of disrupted and impaired attachments. But conversely to that, we see uninhibited attachments, right? So we'll see the children who come in and they meet a new adult, and within 30 seconds of being in my office, I get a big old hug and they tell me they love me, right? Like, that's also a disrupted attachment, right? So being aware that those impaired attachments can be two directional, of either I'm pushing people away and having a hard time forming attachments, or everybody I meet is my best friend, right? And I tell everybody everything, and everybody on the playground is my best friend, and all of the grownups are my best friends, and I love them. Equally deserving of an assessment. Poor academic performance and challenges with those social emotional relationships. This is what toxic stress looks like, right? This is toxic stress in two pictures. So we talked about how toxic stress can build up those levels of cortisol, right? Cortisol is an incredibly important stress hormone. I want cortisol. We need cortisol. However, I only want cortisol when I'm being, chased by a bear or in another really unpleasant situation, because what cortisol does is that it gives me the energy and the ability to run from a dangerous situation, right? It is a big boost of energy that says, go, right? Fight, flight, let's go, let's get out of here, let's keep yourself safe, let's handle this threat. And thank goodness that cortisol shows up and allows us to do that in traumatic or unsafe situations. However, what happens when cortisol builds up and we are in a constant toxic stress state is I'm now sitting in my chair doing nothing. There's no one chasing me. There's no bear coming after me. And my brain thinks that there is, right? I'm in that state of hyperarousal. My body is getting the signal that something awful is happening. It produces this level of cortisol, and there's nowhere for it to go, right? Because I don't need to go run from a bear. And this level of cortisol that builds up over time is one of the things that we see in chronic health conditions. This is a little bit off subject, right? But we see a lot of adults who will complain of things like vestibular fat, right? And it's fat that no matter how much we diet and exercise isn't going to go away. It's the result of cortisol overproduction and buildup over time from being in a state of toxic stress. And we see a lot of other health issues related to that. But I just like these images, right? Because this is exactly what's happening for our children with ACEs, is our brain is giving the signal, run, right? Do something, address this traumatic event, but it's not happening in real time. And so we're not using all of those hormones that our body's producing. And that can send us into a really complicated hormonal state, which leads to all of those other symptoms we were talking about earlier. But as we're working with children, right, and they're exhibiting these behaviors, they've got, they're acting out in class, or they won't sit still for their session, or they're kicking their sister, whatever they may be doing. The first question we want to ask is, what's the underlying basic human need here, right? Is the child wiggling because he needs to go potty, right? Like, do they just need to go to the bathroom? They can't sit still. Is it the class period before lunchtime, right? And they're having a hard time concentrating because they're hungry, right? Like, is there a human need, a basic human need here at play that we can pretty easily explain the behavior and attribute that behavior to? After we assess basic human needs, right, we're looking at developmental stages, right? So is this reflective of the age and developmental stage of the child, right? If I'm working with a bunch of teenagers and they're not paying attention and their heads are down on their desk, I don't know, is it because this is a 16-year-old teen who stayed up too late last night and we know needs more sleep than they do at other developmental stages and they're not getting it, right? Do I have a kiddo who maybe forgot their homework, right, but is 11 or 12 and we know doesn't have the brain development yet to have all those advanced planning skills to bring in their homework every day? We're kind of thinking, okay, like, are these concerns or these behaviors things that as development changes will alleviate on their own? We also want to address the current state of the nervous system, right? So again, we've talked about like when I'm super excited about something, or I'm really nervous or freaked out about something, it is so much harder to concentrate, right? Let alone like learn things and remember them. I'll give an example of my daughter here, right? Like, she's a pretty good kid. She's 7 and she's not a troublemaker at school. But the other day they had a guest speaker and she had a tough time holding it together, right? Like, probably the first time she's in 2nd grade, the first time ever that her report from the day was like, hey, my teacher told me I was blurting out too many times. And she was in tears about it. It was very out of the norm for her, right? But like, she was so excited and her class was so amped up that this cool new person was coming in. It was for junior achievement, right? Like, coming in and talking about things that they don't normally talk about and getting to do fun things that they couldn't concentrate, right? That was an excited reaction. Opposite of an excited reaction is a scary reaction, right? I have a 3-year-old who is now petrified of fire drills. They had a fire drill at school and that did not go well. And for months now, we now have to explain when the microwave beeps and the washing machine makes a noise and when anything, sounds like anything, because that nervous system got so dysregulated from that experience. And so if I'm working with kids, right, and they're exhibiting those nervous system disruptions, I need to take a step back as an adult and go, okay, right? Like, this behavior, while maybe not a tolerable behavior, not an acceptable behavior, is currently being attributed to the state of their nervous system, right? Oh, that was weird. I don't know if it flashed on your side, but the next thing we want to look at, right, is this student stressed? Like, have they entered fight, flight, or freeze, right? Like, has their nervous system become so dysregulated that they are experiencing a survival response, right? That is something that, again, we are programmed to do this. And And so we may see a kid who's like present in the situation, but we can tell is completely tuned out, right? Are they kind of on in their own space, in their own headspace right now? And so we want to be mindful of like, are they in a survival response? I have a provider right now who has a client who's constantly getting in trouble at school because they throw objects, right? Well, if an intruder entered the school and somebody threw a chair at them, we wouldn't be upset with them for that behavior. So while we don't want a student throwing chairs at nothing, we need to assess what's maybe triggering that survival response in them, what's activating for them. Are they trying to use a coping skill that no longer works, right? Kids have amazing coping skills. They have figured out how to survive a lot of things, right? Kids with high ACEs have incredible amounts of coping skills, but they may not be functional when those ACEs are gone or they're out of that situation, right? And so, kind of an example might be even facial expressions, right? If my neighborhood is really, really difficult and dangerous, I may have to learn how to have a really hardened face and a stare that protects me when I'm walking from the bus to my house, right? Or whatever it may be. However, that same facial expression given to a teacher in my classroom is going to be perceived really, really differently. I don't need that coping skill when I'm struggling with math, right? And so kind of assessing where that behavior comes from and recognizing that those coping skills that maybe aren't needed outside of those traumatic environments are the same coping skills that kept those kids alive, right? We talked about it, right? What are the structural changes to the brain? What has that long-term exposure to toxic stress done? Are we working with kids who have depression, right? Are they really black and white thinkers, right? Have they lost some abstract thought? How are they reading social cues? And just kind of thinking about, what might be going on inside that brain. We might also be looking at what we call trauma-induced thinking and conditioning, right? Because trauma changes the way we see the world. I was just talking to somebody the other day, and somebody said something very, very benign, very, no big deal, very matter of fact. But because of a life event of mine, the first place my brain went to was not a great place, right? And it was like, oh, wait, like that's not what they said, right? They said something completely different. But our brain learns to, again, talking about going back to our neurons firing, right? And expecting outcomes. We're learning, okay, bad things may happen, right? We see a lot of kids who are really, really naughty because people in their life have abandoned them, right? So I'm simply trying to figure out, how naughty do I have to be before you give up on me as well? And testing out those behaviors, right? Because then I'm right? I knew you were going to quit on me. I knew you were going to say I was a bad kid. I just had to be a little bit naughtier, right? Because you wanted to help me. You said you were going to help me, but I knew once you saw, the bad in me, you'd leave. So they're really trying to kind of fulfill that narrative that their brain has created. And then it becomes our job, right, to ask, how is this problem the child's solution, right? So even if the behavior is problematic for us, right, it's something to that child. So again, going back to that client I was talking about who throws lots of objects in school, right? School is very overstimulating for this child. Their narrative is, I'm a bad kid and everybody gives up on me. So if you throw a chair, right, the school's current answer is to send them home. And so for weeks now, this child has gotten dysregulated in school and thrown a chair and gotten sent home. And so this problem of throwing chairs is 100% the child's solution, because now they get to go home and escape a difficult and overwhelming situation, right? So we really need to to consider these things, right? And be open of, okay, what's under the behavior, so that we can help shape these children to making different decisions, improving outcomes. So some of you may have heard this, the infamous Bruce Perry and Oprah Winfrey conversation, but it really does become our job to ask about what's happening or what happened to children instead of what's wrong with you, and being open to hearing what they've experienced versus simply targeting those behaviors. What can we do, right? Just as adults in general, right? Outside of therapeutic interventions, just as an adult in a child's life who's experienced ACEs, we can help to create a sense of safety, right? So this may be a safe place for them to come to. It might be a feeling that we help them create. We can help them find coping skills that work, right? Or coping skills that work and are appropriate and effective in their new environments. We can build those connected relationships, right? We want to build that oxytocin. We want to calm our nervous system, and we can do that from building those relationships with a trusted caregiver, adult person in our lives. Predictability is so important, and helping children have routines and know that they can count on some adults. One of the things that schools get so annoyed with me about, that I will forever continue doing, when they have a child who's really exhibiting a lot of difficult behaviors, the tendency, right, because of our structure, is to take that child aside, right? And they're in trouble and they go wherever they go when they get in trouble, right? I ask them to trust me a little bit. And I have a school I just implemented this with last week, but I ask them to trust me a little bit. And I ask them if that child can identify one adult in school that they like, or sometimes it's the adult they hate the least, right? Like, who is that one person that child could maybe connect with? And I ask them to set aside 5 minutes of every single day at the same time of day to spend with that child. And the biggest piece that has to be at the same time, right? So before lunch or right after math or whatever that time may be, it needs to be at the same time every single day. And it's unconditional. So I don't care if the child threw a chair that morning. I don't care if the child spit on their desk. I don't care, obviously, aside from really egregious safety concerns that the school would need to still have those parameters in place. But this relationship, this time, this 5 minutes with this adult is unconditional. And if they trust me and they see it through for a few weeks, we really have seen some incredible turnarounds, because that child starts to learn that there are reliable adults and there are people that care about them, and that their relationships are not dependent on their behavior, which really mimics that unconditional love between a parent and a child in safe and healthy relationships. So when children aren't getting that, right, they're learning, I can care about you even if I disagree with your behaviors today, right? Or I can care about you even if you made a decision that we're not going to, we don't want to make again. And so that reliability, that predictability. In practice, just lost you guys, helping them find ways to have some autonomy, right? And be able to gain some power that so often we lose in trauma situations. And those don't have to be like massive situations, right? Like, hey, we need to wear a coat today. Do you want to wear this red one or this blue one? Right? Like, I'm still allowing them to make a decision, and I'm trusting them to make a decision. And we can give them that respect to do that. Helping them learn to care for one another. It feels good to help somebody else, right? So putting them in situations where we can safely do that. And helping them learn problem solving skills, right? And we'll talk about what this looks like in the therapy room as well, right? But these are things that we can all do as adults in the lives of children. But it is recommended that children who have been exposed to ACEs receive victim-focused mental health treatment. And like we talked about this, the sooner we can intervene, the greater likelihood we have for helpful outcomes. What we see on our end of things and what can show up are a lot of different diagnoses resulting from ACEs. We see like acute stress disorder, post-traumatic stress disorder, various adjustment disorders, trauma and stressor related disorders. What we also see a lot of that often can be inaccurate are things like ADHD, right? Oppositional defiant disorder, conduct disorder. We see a lot of these disorders show up that maybe aren't quite accurate. And so when we're looking at somebody's ACEs and somebody's trauma history, we want to be mindful of making sure that we're gathering information that helps us form a diagnosis that makes the most sense. A lot of trauma behaviors can look ADHD when they're not. And so we want to be mindful of that. It's often misdiagnosed and can be really overly diagnosed. And the problem with that is then our treatment isn't appropriate. It can be confusing. We can end up with kids that are prescribed medication that isn't working because it's not treating the diagnosis. It's treating ADHD, which the child may not have, which can lead to side effects and negative health outcomes. And so we really want to make sure, it's not to say that a child with ACEs can't also have ADHD. That absolutely can happen. But we want to be mindful that children are getting appropriate diagnoses. So just, there can be some challenges as well. It talks about some challenges with post-traumatic stress disorder. The diagnosis of post-traumatic stress disorder in the DSM, which dictates how a provider makes that diagnosis, does have some specifications for children. There's some arguments on the clinical sites that they're not enough to get an accurate diagnosis. Over the last several years, there's been some clinicians that have tried to advocate for a diagnosis more tailored and suited for children who have experienced ACEs and chronic toxic stress. It doesn't exist yet outside of these diagnoses, but really being able to take the pieces that we do know and set children up for success by diagnosing them accurately. I talk to parents all the time about, it can be really scary to get a diagnosis, right? It's like, oh, like, okay, like ADHD. Yeah, everybody's got ADHD. That's fine. Whatever. Yeah. Like, but hearing post-traumatic stress disorder or acute stress disorder, those sound like big diagnoses, right? But they really can be so validating when we take into consideration of like, yeah, like what's happening for this child is so real and so important that there's a diagnosis that describes it. And once we have that accurate diagnosis, then we can come up with a treatment plan to help this child therapeutically. So just making sure that we're mindful of what that process looks like, and being as accurate as we can. Very much. So there's lots of types of therapy that can be useful, and there isn't anything that says it has to be one or the other, or that only this type of therapy will work. These are all evidence-based models. They all have a high structure and an understanding to them. They all need to be done by a licensed mental health professional. They just have different treatment approaches. Trauma-focused cognitive behavioral therapy is one we talk about a lot. It can be a wonderful therapy. I use it myself quite often One of the caveats to that is it requires a lot of cognitive skills, hence cognitive behavioral therapy. And sometimes kids with high level ACEs and significant trauma backgrounds don't have that cognitive functioning yet. So that isn't always the route that we want to go. Stemming from that, D-Ray came up with trauma-focused integrated play therapy, which is exactly what it sounds like, and integrating some of the concepts of a trauma-focused cognitive behavioral therapy with play therapy structures. TheraPlay is a phenomenal, highly attachment-based type of therapy. If you were at yesterday's training with Tammy, Tammy is trained in therapy. It is a whole nother kind of certification process in and of itself. It's a wonderful intervention, but again, needs to be done by somebody who has that specific training. The neurosequential model of therapeutics is a fun one to say. We're going to talk more about that one. It's not the primary type of therapy we're going to discuss today. We're going to talk about child-centered play therapy. But when we're thinking about ACEs and how to address ACEs in therapy, it's an important model to attend to. It's developed by Bruce Perry, and we'll talk about kind of how that overlaps with child-centered play therapy. So this is that neurosequential model of therapeutics, right? And Bruce Perry talks about the hierarchy of brain function, and we talk about this quite a bit when working with children, right? And are we down in our brainstem? Are we in our midbrain, our limbic system, or our cortical system? And as we move through those brain functions, the operation of our brain, becomes more advanced. So that brainstem is controlling things like our body temperature, our heart rate, our blood pressure, right? Our basics of human survival are controlled by our brainstem. As we move up that hierarchy of brain function, we get into things, like appetite and emotional reactivity, attachment, right? Concrete thought, abstract thought. And so understanding how those pieces of our brain kind of come together, like we saw in that video earlier, and those building blocks, how they work together to create a functional brain that's able to do all of the things that we want a human brain to be able to do. And when we take that pyramid and we break it down into kind of a brain map, this is what we get. And we get these building blocks. All of these pieces come together, right? And let us know which pieces the child has. And so Bruce Perry and his team have a phenomenal assessment where they are able to assess which pieces of this brain map are there, which ones are where they're supposed to be, which ones are missing, which ones didn't quite get there. It's sort of like building a Lego tower, right? And knowing, okay, I'm missing this piece, or I have this piece, but it would be better and stronger if we had this one. And so again, going through that hierarchy of the brain and, looking at developmentally from birth through about age 11. So birth being down in the pink section and moving up as we get older with those pieces of the brain that are forming in conjunction with our support networks and with our social connections and the feedback we're getting from adults in our lives. We won't go through all of them, but what I think is really interesting to show, right, is these are some examples of what we would expect to see, right? So on the bottom are kind of typical age ranges. So the first two on the bottom are what we would expect to see for kids ages 6 to 7, right? So those lower brainstem functions should be in that green 11 to 12, right? They're developed, they're within typical range. They should have those building blocks in place. A lot of that midbrain area, it should be showing up, right? It should be there sometimes. It should be, it should be emerging, those yellow ones on top, right? That's more of our abstract and concrete thinking, kind of, right? Like it's not quite there, but like it should be kind of there. What we see above that, right? Those maps above that are kids that have experienced various levels of traumatic events. And so just being able to see, okay, like this child is missing these building blocks, and this child doesn't have what we would expect them to have at this moment in time. It's just a really incredible way to view the brain and to view the functioning pieces of the brain. And what MMT and TheraPlay and other play-based activities talk about is how do we recreate that, right? So some of those brainstem and kind of attachment-based pieces, right? If we think about having an infant baby, right? And we hold the baby and we make eye contact with the baby, right? We saw that again in that building blocks video of those back and forth exchanges. And now I have a 10-year-old in my office who's missing some of those building blocks. I'm not going to scoop up this 10-year-old and rock them, right? But I may have a trusted caregiver lay them on the floor and wrap them up in a blanket and play burrito, right? And I may give them that same type of swaddling experience in an age appropriate fashion, right? I may have a caregiver in their life scoop them up and swing them as they look at them and sing a silly song and throw them onto a bed, right? And play a game. And so we have a lot of ways to kind of build those building blocks that are missing from early childhood in a way that may be age appropriate for that client in a session. But yeah, we could do, I did a 10-week training with Bruce Perry. We could do 10 weeks plus on this. We're going to do about 10 seconds today, but I like being able to show what those brain maps look like and what that trauma can do to developing brains. So what do we want to kind of strategize for when we're thinking about doing therapy with children who have experienced ACEs? We want structure, right? We want consistency first and foremost. Sitting in the same spot at the start of every session, they can tell me to move. They can ask, they can put me where they want me during session, but I'm going to start in the same way. I need to make sure as a provider that I'm showing up at the date and times that we agree to, that's consistent. We don't want providers that are constantly canceling or rescheduling or moving things around on families. We want to set limits, right? And that can be done a lot of different ways in play therapy, but appropriate limit setting and obviously creating a sense of safety for those clients. We're engaging in verbal and nonverbal responses. Those nonverbal responses, right, are equally as important. Am I looking at that child? Am I paying attention to them? What are they gathering from me even when I'm not speaking? And I'm using those to develop that relationship with them, which for many children can be brand new. When we think about the higher ACE scores and that exposure to toxic stress, new relationships are scary, right? And the brain has learned adults may hurt me, or adults aren't trustworthy, or adults are unsafe. And we're trying to rewrite that narrative, but it's not an overnight process. We also want to make sure that they have a nurturing environment so that they can regulate and calm, right? And learn to nurture on demand, right? So leading to some emotional regulation and helping them figure out what that looks like for them. It's, we want to nurture them when they need it. And that can be something they're not used to as well. That can be really scary for kids who aren't trusting of adults. So just being mindful of that. And then also making sure that eventually we're challenging these children, right? We're helping them figure out how to problem solve and create a world in which they are able to attend to the situations that come up for them. Play therapy has been around a really long time. It's not new. It has been around since the early 1900s. And Virginia Axeline is one of the first people to really start to put elements of play therapy out into the world. There's a wonderful book called Dibs in Search of Self that talks about her clinical relationship with a client and what that play therapy looked like. But what Virginia Axeline talks about is what we've come to know as play therapy, right? That children's language is through play, and that the playroom is the best place for them to grow. And we want them to have an environment where they can express themselves and they can freely share with us their emotions. And to kind of capture that, Virginia Axeline came up with 8 principles of non-directive play therapy. And again, they're fairly straightforward, but they've stood the test of time, right? Like she put this out there in 1947, and they have weathered the growth of play therapy. We want that therapist to be warm. We want them to create a friendly relationship with that child, and we want to do that as soon as we're able to. That again doesn't mean it's going to happen overnight, but we want that child to start to be able to have a relationship with that therapist. We want that to be unconditional, right? When we think about the roots and Carl Rogers and person-centered therapy, right? This is pulling from that, and the child is exactly who they are, and that is exactly who we want them to be. We want to give that child permission to feel free to express their feelings completely, right? They're not in this therapeutic relationship to please the therapist or to make the therapist happy. Like they are there to express themselves however they need to. We want the therapist to be able to recognize that the feelings that the child is expressing and reflect those back. Sometimes our children are sharing really big feelings that they don't have words for, right? Or they don't know what that is. We have a client right now who does exactly that. Will tell their therapist, I don't know what to do with these big feelings, but can't name those big feelings, right? So the therapist is able to reflect those and help that child gain awareness and mastery over what that feeling is. We also are trusting that the child can solve their own problems, right? And that's a hard one to explain to parents sometimes, right? I'm not going to go in and like problem solve for this client. I trust this child completely to be able to solve those problems when they're given the opportunity to do so. I'm not directing their actions. I'm not guiding the conversation. Again, it's a hard one for parents who are like, can you talk to them about how they got in trouble at school this week? No, right? Like maybe, I don't know if they bring it up. If I'm engaging in non-directive play, I'm not doing that. So I'm not hurrying the therapy along. This, ACEs don't happen overnight, and neither does healing. Again, our society wants things to go really, really, really quickly. And if I have an 8-year-old client who was just placed into foster care, that's 8 years, right, of traumatic events that I can't undo in a 1-hour session. And so giving realistic treatment plan goals and timelines. And I'm really only setting limits that are necessary. And I do that kind of on a case-by-case basis, right? I do that in the moment basis. Those limits can look pretty different, and they're pretty lenient in the therapy room. But I do want the child to be safe, right? So a lot of my limit setting has to do with the principle of safety in mind. These are just kind of pulling on some of that work as well. Gary Landreth, we'll talk a lot about Gary Landreth. He developed the Center for Play Therapy. It's in Texas. It's a wonderful, wonderful institution of knowledge and research and play, and so much work on child-centered play therapy comes from there. And he simply took some propositions of personality and human development way back from Rogers, who, gave us person-centered play therapy and the unconditional positive regard for our clients, and really kind of talked about what that means in the play therapy world. So we don't need to go through all of these, but being mindful that the client's perception is reality. So I don't need to know all of these specifics. I need to know that what the client perceives is real. And so clients will find what they need in my playroom. They will create what they need. There's always controversy of, do you have weapons or not in your playroom? It doesn't matter, right? My clients will find a pen, and it's now a knife or a sword or a gun or whatever they need it to be. And so allowing clients perception to be their reality. We do want to be goal directed, right? And we want to help parents see that, just creating that space, right, for that client grow. Like I said, Gary Landreth really brought to life, created child-centered play therapy. It is a relationship-based form of play therapy. That sentence got totally cut off. I apologize, guys. I'm not even sure what's happening with that slide this morning. But what we will be talking about for the next several slides is child-centered play therapy and what that means when working with children, and understanding the premise of that. Again, it doesn't mean that child-centered play therapy is the end all be all of trauma work. There are millions of options and ways and approaches, and all of them fabulous. But when working with ACEs specifically, I think approaching things from a child-centered perspective gives that child the autonomy that's often been stripped from them due to those traumatic events, and allows them to create an experience and have an experience that really is filtered through their own lens, right? Their own reality. And it challenges us as a provider to see the world through their eyes, right? That is such an incredible gift, to be able to give these children a place that places no value or judgment on that view, right? Things are not good or bad or right or wrong. Like, this is just where the child needs to be. And if I'm willing and able as a provider to look through their eyes at a situation, I really get to understand them a whole heck of a lot better. And so to do that, right, we know that we need to not treat children as miniature adults. They're not. They are amazing human beings that are not simply little adults. They are people. They are unique, and they are worthy of respect. They are incredibly resilient. They have an inherent just tendency and desire to move towards growth, right? I think that growth mindset of a child is something unlike anything else. They're capable of positive self-direction. They want to play, right? If you've been to any of our trainings, right, it is echoed in every single one. That is their language, right? The toys are their words. Like, they are telling us so much through play. They also have the right to be silent, right? Like, right, they can be quiet. They can come in and have a day where they play independently of their provider. They can have a day where they come and they sit. Like, it's okay. It's their session. They will take things where they need them to go. They will show us the growth that they need to make. They'll show us the changes that are making. They'll show us their progress. They'll show us their trauma. and I don't get to control that timeline. So echoing what we learned from Axeline, right? Like their growth cannot be sped up. They will get there when they get there, and kids are amazing, right? We may go weeks and weeks and weeks of repetitive play, and all of a sudden something is new and something is different. That is their timeline. We are just along for the ride with that. It's effective, right? We like child-centered play therapy because it's effective. It's evidence-based. We know that it can work. Now, does it work for every single child in every single situation? Absolutely not, right? We want to take the child's symptoms and needs and presenting issues and unique the decision of which treatment plan to take. It should not be a one-size-fits-all approach. But we know for those that we're doing child-centered play therapy with, that it allows them to have a safe place. They do get to express their emotions. They get to form that relationship with their provider. Like we've talked about, they get to work through their trauma at their own pace. I'm not forcing them to talk through things. It's been around over 70 years, right? And we can do it lots of places. So we've got school-based providers, we've got clinical providers, we've got traveling providers. It's pretty adaptable so that we can meet the client where they're at, literally and figuratively. We've talked a lot about the brain's changes, right? But one that is crucial to understanding why play therapy is so important for working with ACEs is another part of the brain that can be affected by ACEs is Broca's region. And this is the region that's responsible for speech. So even when we want them to, right? And let's just talk about scary thing that happened. May not be able to. Right. One rule of thumb that I tell people all the time too is if they didn't have the verbal capacity when the trauma happened, no matter how intelligent they become, no matter how well spoken they become, we may never have the words for that trauma. And so giving them a way to talk about the trauma without using verbal expression is so powerful. Even for adults, right? I do a lot of play therapy and expressive arts therapy with adults with ACEs because they were kids when those happened, right? And no matter how well put together they are as adults and how well spoken they are, that part of their brain was a baby, was a child when those ACEs happened, and they need to express that as well. We've talked a lot about these, right? Just making sure that we are creating an environment for the child in play therapy where they can test the things that they need to in a way that they want to. Child-centered play therapy asks the therapist or calls the therapist, right, to be someone and not just do something. I think that it is such a powerful way to look at the role of a provider, right? When we're working with those children, it's not enough, right? We're not just showing up with a checklist of tasks or a workbook of interventions, right? Child-centered play therapy is asking us to be someone for this child. We are becoming a safe and reliable and consistent person in this child's life. We are becoming someone who is creating that sense of safety for them. We are genuine, right? Like it is such a powerful thought to know we need to be someone versus just do something for those children. The other thing we're paying attention to in play therapy, and this is fairly new, although every time I look at references, I feel older and older, right? But updated most recently in 2011. And then this came from research focused on children that had experienced ACEs and their play in general, right? So just looking at how do children with high ACE scores play. And what Myers was able to come up with was really kind of 5 domains that became what we know as the trauma play scale. So kids who have experienced ACEs have really intense play, right? It might be compulsive play. It lacks joy. It's not spontaneous. It's a very focused, compulsive play. they may have some repetitive play, right? So this, every time I come in the playroom, I do the same thing with the same toy. It has a lot of meaning. I had a client one time who used the same figure in my playroom every single time. And somebody had come into that playroom between sessions, and not maliciously, but I think somebody had let somebody's little sibling come in, not quite sure what happened. And that toy went missing. And we spent the entire next session, and I didn't know what had gone missing, looking for that toy, because that on that trauma play scale, we were in the height of repetitive play. And I wasn't quite sure what that figure meant to the child at that time, but we knew we needed it, right? And we knew we needed it because we were repeating play over and over and over and over again, which goes into what we were talking about earlier, right? Of being consistent with these clients. That was a hard day, because that consistency was disrupted because what that client needed wasn't there. Play disruption, right? Is a play that is so strong for that child that it causes them to dissociate, right? So kids will be playing and they really won't be connected to anything else in the room. They lose track of time and space and where they are because they are so connected to that play that they are engaged in. Avoidant play. There are kids that come in and they will actively avoid the therapist, and that's okay, right? They're engaged in avoidant play. Back to you, turned around, huddled up in the corner. I've had kids tell me, like, don't move, right? Kids that'll ask me to close my eyes, like they want nothing to do with the therapist when they're in avoidant play. An expression of negative affect, right? So these may be kids that are playing with a lack of any sort of feeling expression, or kids that are playing and expressing a significant amount of negative feelings, right? So there isn't any joy or happiness in that play. There's a lot of negative feelings being expressed in that play. Nadine Burke-Harris is wonderful. If you haven't taken a dive into any of her work, please do. She has some incredible work on ACES, but I've got two of her quotes in here, but what she lets us know is that the body of research sparked by the ACE study makes it clear that adverse childhood experiences in and of themselves are a risk factor for many of the most common and serious diseases in the United States and worldwide, regardless of income or race or access to care, right? ACEs don't matter. What we know is that simply experiencing those adverse childhood experiences put us at risk. There are protective factors. We're going to talk about protective factors, but we need to be aware that ACEs don't care where we come from. There are some cultural challenges to studying ACEs. Primarily, most studies have happened in the United States or in the United Kingdom, which is, putting research in some of the most affluent countries we have. But disregarding that 90% of the world's children live in poorer countries, right? So we have got tons of research, great, wonderful. 90% of that research is failing to neglect the areas where our children are living in poverty. In these parts of the world, right, violent events, youth homicide, and other events are much more common, right? And we just know so little about the type of trauma experienced within those cultural contexts, right? So we're learning what youth homicide means to youth in the United States, right? And we're learning the mental health impact that gang violence may have to children here in the United States. But what we're failing, and we're trying, right? But what the research is currently really lacking is an understanding of what impact that has in countries where those things are much more common, and what that may mean as far as ACE scores go for children in those countries. We talked about this earlier as well, right? As we continue our research on ACEs, we do want to be mindful of other types of adverse childhood experiences, right? Exposure to racism and discrimination and violence and bullying, right? And it's essential that we expand our knowledge and our research and our understanding of these, because we really want to be able to accurately depict what's happening in the world around us, right? Those 10 original ACE questions are incredibly important. But as our world grows and expands and we become more knowledgeable, we can't forget or undermine that there are lots of other adverse experiences that are impacting our youth. Another one by Dr. Nadine Burke-Harris, but she also lets us know that one of the biggest myths that we have to bust is that that if you have experienced childhood adversity, there's nothing we can do about it, right? This is not something happened, I'm just going, that's it, right? I'm going to be faced with a lifetime of adversity, and I'm going to have early death and disease, right? Like we can do things about it. And we should be doing things about it, right? These are some ways that we can help challenge ACEs, right? So we've talked a lot about support, right? And making sure that families have access to the things that they need, right? Can we help make sure that families have access to food and clothing, housing, and transportation? We help foster social and emotional competence, right? What can we do to help make sure that kids are being exposed to those types of situations? Resilience, we're going to talk more about resilience, but helping parents learn resilience as well, right? As parents learn resilience, they're modeling resilience, and as a result, they're teaching resilience to their children. Keeping families connected, right? I'm in Marion. The Cedar Rapids area does a fabulous job, especially with our foster and adoptive care networks, of keeping parents and caregivers connected. They have so many social networking events and things that they put together for those families, but things like that, right? I'm not alone in this. And providing knowledge of parenting and child development. We have been fortunate enough to be able to give some trainings and some support to like our young parents network and things like that, right? Of just helping them know, okay, like these are things that we can help you to know and practice and feel a sense of increased ability, right? And being able to do those things independently at home. And helping children find nurturing relationships, right? How can we talked about it? It doesn't necessarily have to be a parent or guardian or caregiver, but what can we do to support some nurturing and attachment relationships in those children's lives? And we can do that through modeling and teaching and building resilience, right? Resilience happens for kids, again, by forming those close relationships, by seeing parents model resilience. These are all the things that we talked a little bit about on that previous slide, right? But having a sense of purpose, right? Whether that's through faith or culture or identity or whatever that might be, right? Helping kids find a sense of purpose and feeling competent in their abilities, right? What can they do? How can they solve their own problems? Helping them connect to their communities. Right? So again, this is all kind of repetitive, but things that we can do, right, to build that resilience. One-on-one time. Right? We talked about that. I talked about that with the school. We want parents to give one-on-one time, even if it's 5 minutes, right? I think sometimes it's an overwhelming task of like, oh, I can't spend an hour one-on-one with all of my kids. I have 5 or 6 kids. 5 minutes, right? With like no cell phones and no distractions. And just give them that space, right? To hang with you, to be with you for a little bit of time. Promoting healthy risk taking, right? We are in a world where everything is dangerous and everything, has to be made as safe as possible. Where we can, we want to encourage them to take some healthy risks, right? Whether that's trying a new activity or a new sport or talking to someone new, right? Or for my child, like getting her to try school lunch for the first time, right? Was a safe risk-taking behavior. But helping them try some things that are a little bit scary, but we know are safe. resisting the urge to fix it, right? This thing is wrong. Like something happened at school, or my best friend said this, or whatever. Ask questions first, right? Let them explore the problem so that we can teach those problem-solving skills and work with them, not for them, right? We want children to be able to trust their abilities to solve problems. Labeling emotions, right? Again, like it's okay. Grown-ups feel emotions. We have feelings, and labeling them, right? I was sad the other day, right? And it was crying a little, and my kids, mom's sad, right? Sometimes mommies feel sad, and mommy's okay. Mommy just feels a little sad, right? Like we can label and normalize those emotions for children and demonstrate coping skills, right? Sometimes mommy needs to take a deep breath or take a walk or, whatever it may be. And talking about like why we're doing those things. They don't need the grown-up version of why, right? But mommy had a big sad feeling, and so mommy is going to take a deep breath, right? We can demonstrate how to use those coping skills and embrace our mistakes, right? We're not perfect. I don't want anybody to be perfect, but embracing our mistakes as adults and embracing their mistakes and normalizing that mistakes happen when we try new things. Promoting the bright side, right? If we have a kind of inherently pessimistic kiddo, right? Like helping find that optimism. We play high-low buffalo every day at my house, without fail, right? And so exploring the best part of the day, and we can identify the worst part of the day, right? And our buffalo is just something random that happened throughout the day. But playing high-low buffalo, right? And finding the optimism in those things. And even if the day was bad, right? If I have 100 lows, I've still got to identify a high for the day, right? Which can help with that. Modeling our own resiliency and going outside, right? This time of year is so tough. Our brain, which makes us more receptive to resilience building skills. And so playing outside, going for a walk, taking fresh air, doing what we can to get them up and moving and outside when we can. Active factors, right? I won't go through all of this, but it allows us to kind of have a sheet, just like the ACES assessment, that looks through what their protective factors were and which of those they had as a child, and which ones are still true, and kind of exploring what that world looks like.
Thank you for joining in on today's training. We look forward to having you join us again. Heart & Solutions is proud to provide CE-eligible trainings for our counseling community. This training may be eligible for continuing education credit hours through either the National Board for Certified Counselors, provider number 7376, or the Association of Play Therapy, provider number 21-645. To obtain CE hours for today's training, be sure to follow the steps in the description below.